All right, welcome back. Thank you very much again to our first panelist. Excellent way for us to start off here today. We've got an interesting kind of combination of folks coming up next. Actually take a little bit of a different bent on this for us, looking at policy as a driver of mental wellness. I am joined today by our moderator, who is Assistant Vice President for Student Development, Health, Wellness, Jake Baggott. Welcome, Jake.
Thank you, Devin. It's certainly a pleasure to be here, and it was really nice to start off with a session like we did. We had campus leaders that are that forward-thinking and engaged and really paying attention to these kinds of issues. That just makes all of our lives so much more satisfying and productive. So our panel, as Devin indicated, is policy as a driver of mental wellness. And we're focusing on the interaction between politics and policy and the regulation and development of mental health care and treatment options. It goes without saying that one of the chief focuses this year here in the nation's capital has been the future of our national health care system. With so much of those discussions and debates revolve around issues like insurance or physical medicine, policy development around mental health and potential treatments often takes a back burner. The reality makes the work of mental health advocates, especially the Mental Health Caucus, all the more important. We are fortunate today, as they join me, this morning to be joined by two staff officials who deal with mental health policy. Jennifer Wood is a legislative assistant with the New York Congressman John Katko's office. She is a graduate of this very campus and has been working on the Hill since 2014. She currently assists the Congressman with his health care and mental health care policy agenda. Jonah Cunningham is a senior policy advisor in the office of California Congresswoman Grace Napolitano. He is a graduate of the University of Utah and has been on the Hill since 2012. He has been a leading coordinator of the mental health policy, including administering health care for veterans and mental health legislation portfolios, and organizing the Congresswoman's mental health task force of high-profile individuals to reduce stigma and increase awareness of the mental health-related issues. Ms. Wood, Mr. Cunningham, thank you for joining us this morning. So we're going to begin with a series of questions and give each of you a chance to consider those and share your thoughts about that. So as discussions continue around whether or not to distribute essential health benefits in various legislation and regulatory proposals, how do you see Congress addressing this issue to centralize or decentralize, and what impact will this have on mental health services? Mr. Cunningham?
Ooh, that's a doozy. Congress and healthcare. So I would start off by saying that it's already been kind of decentralized, where the ACA allowed the Secretary of Health and Human Services to clarify what an adequate health program is. Again, they kind of punted it to the states to have what are so-called benchmark plans. What do they mean by mental health care? You know, how many therapy sessions must a healthcare plan have? So now the issue is waivers. CMS, HHS, they seem, depending on the day, whether they're receptive to it or not, is difficult to tell. I think this kind of underlies the issue with mental health is it's kind of a layer cake approach where traditionally since the 50s it's been a state issue where states oftentimes fund, the housing, they have departments of mental health, and the federal government, the main proponent of it is SAMHSA, and they're a block grant, the Substance Abuse Mental Health Services Administration, and they are a block grant program, giving block grants to states, and then also specific individual grant programs like the Garrett-Lee-Smith Act for suicide prevention. Within this layer cake, there's a lack of coordination and cooperation, and it's difficult to solve with a silver bullet, but I guess that's me filibustering this question. So it's time will tell.
I'll just add. So Republicans in both the House and Senate, every proposal that they've put forward would have greatly expanded states' access to waivers to either eliminate completely or modify essential health benefits. Republicans failed on every proposal, so I think, should Republicans move forward with another partisan proposal, it likely will include something targeting essential health benefits because that's seen as one of the primary drivers of cost, at least in the individual marketplace. And that's something that advocacy groups and people who are opposed to that need to address, the cost issue, and how, are providing essential health benefits, how is that cost effective? Looking at the long-term scoring and how, providing that care now is saving in the long run. So now that Republicans have failed, should a bipartisan policy move forward, which seems like the only way forward for cost-sharing reductions and other things that need to be addressed, it's likely that essential health benefits won't be included, but considering we have at least a year left, of Republican control of Congress, this is, going to be an issue going forward that really needs to be addressed in terms of cost of essential health benefits and how do you counter those attacks.
Thank you. So the next one's challenging as well. We continue to hear about the link between mental health and guns. As we see a number of states and college campuses allowing open carry, how do you see Congress dealing with this issue or not, and why? Would you like to start?
Sure. Guns are a complex issue, and I think, I handle mental health care. So whenever I talk about this issue with my boss, I focus on suicide, the leading cause of gun deaths in our country and vastly overlooked. When we have these mass shootings, the attention goes to them, which, it's a tragedy and it should, but there's a huge issue that needs to be addressed, and policy-wise, the attention on the Hill isn't necessarily there. I think, I'm not too familiar personally with the open carry laws going on college campuses. I think, a lot of people in Congress view it as a state issue, that states are deciding and they need to work with their colleges and universities to address that. I think sort of the growing focus now related to this issue has to do with background checks, at least in sort of the bipartisan compromise area of Congress, the NICS system, the gaps that are there, the people who are falling between the cracks. There's a huge contingency of people that want to expand the background check system, but there's already current flaws that are there. We saw that with the Texas shooter. We see it with a lot of people who are checked into mental health institutions, who have domestic violence histories, who have drug felony possessions, and those people are not correctly put into the system. Whether that's a fault due to the FBI and a backlog, lack of funding, or a lot of faults on state and local police forces and all the way up through the military, as we saw with the Air Force, just not having the resources, not having the policy in place to really report those things and make sure they get into the federal system. That's sort of a growing area of focus that I think there's some bipartisan compromise on that we can really work to address through funding and policy reforms.
Mr. Cunningham, what are your thoughts?
So this is an issue my boss has kind of examined, both with one foot in the Mental Health Caucus, another foot, she's a co-chair of the Gun Violence Prevention Task Force that was established after Newtown. And these acts are horrible. They are heinous. And oftentimes the media searches out for a reason, right? And mental illness is often the easiest culprit to point out. He was taking Valium. He, was bipolar. But mental illness, as I'm sure you guys know, is a huge spectrum. It's anxiety. On the far end, I often term mental wellness, right? Kind of those mood fluctuations throughout the day. Then you have anxiety, minor depression, some episodic issues, for lack of a better term. Then you go into serious mental illness territory. Now, blaming all of mental illness, all of mental health for gun violence, when 1 in 3 people have some issue on the spectrum, is kind of foolhardy. On top of that, I lost my train of thought. I have not had my cup of coffee, so please bear with me. Research has shown, I highly encourage you to look up the American Journal of Public Health. They did a great report on American politics, mental illness, and during their literature review for this report showed less than 5% of mass shootings were done by someone that was psychotic, was experiencing psychosis. So if it's not mental illness, what is it? Oftentimes it's a history of domestic violence, it's a history of violence, or multiple DUIs, risky behavior. The issue is, by the time we hold the sign like, wait, you're stigmatizing mental illness, let's talk about this, read these reports, the horse has already left the barn. People already want to talk about mental health, they want to stigmatize. And then the difficulty is it results in some very difficult policy proposals. Like I've heard, have them undergo a mental health screening, which in theory sounds great, but I'm sure if you talk to a psychologist or psychiatrist, they don't want to be in the position to predict future violence. Human behavior is very difficult to predict, especially when it becomes, violent. But there are some safeguards, as she mentioned, the NICS system, shoring that up. There will be some proposals for that. But as the correlation of mental illness and gun violence, it's something that we strongly contest. There are overlap. There definitely is. But there are stronger correlations, as I said, domestic violence and DUIs that should be, that aren't part of the NICS system that maybe we should look into it. I know short-term restraining orders are not part of the NICS system currently. So.
Thank you. Appreciate that. Another issue that we all are trying to grapple with and figure out how to manage, and we certainly would be interested in what your offices are thinking about this, is the opioid crisis. It continues to grow in our nation, and the link between opioid abuse and mental health has been well documented. According to the Journal of the American Board of Family Medicine, 39 million Americans have been diagnosed with mental illness, and among those, more than 7 million, or 18%, are prescribed opioids each year. What can Congress do? What's its role legislatively to help build systems of prevention and greater treatment and recovery options? Would you like to tackle that?
So there's a lot of similarities between mental illness and opioid abuse. They take years to cure. It's an ongoing everyday process. Treatment itself is time-intensive and costly. But there have been encouraging an encouraging movement to recognize opioid abuse, to monitor prescription drugs, to distribute Naxalon to first responders to help save lives. And then, of course, President Trump, his declaration, which also allowed for the aforementioned waivers, specifically for the Institute of Mental Disease waiver, where Medicaid can now reimburse for hospital beds, over 15 hospital beds for inpatient stays. Great movement. However, it's going to be a long-term process where, people that often undergo treatment for substance abuse and opioid abuse, they fail. It often takes 2, 3, 4, multiple times to go into treatment, to talk to a counselor, to talk to a doctor. Also, coordinated care is needed as well. It's very difficult to treat someone that's homeless, to treat someone that's maybe unemployed or perhaps in and out of jail. So there are some policy prescriptions, but again, no silver bullet, no one piece of legislation, no increase in funding like we did last year with CARA. Is going to solve this problem. It's going to be a long-term solution.
Ms. Wood, what are your thoughts about that?
Yeah, I think I completely agree with Jonah that it's got to be a multi-pronged approach. You've got to look at it sort of in the present, tomorrow, and then 30 years down the road, how are we addressing this? Personally, my boss, and there's a good contingency on the Hill of former federal prosecutors, and they've seen this issue growing. Synthetic drugs that are being mixed with heroin that are causing immediate deaths all across the country are just ravaging places like Syracuse that my boss represents. There's one batch of synthetic drugs that goes out, and it'll be responsible overnight for killing 20 people who are taking a regular dose of heroin that's suddenly laced with a lethal synthetic drug. So for years, these drugs were impossible, basically, to put on the schedule. It would, by the time you identify the compound, it would take 4 years for the DEA to be able to put it on the schedule and take it off the streets. My boss put out a bill that would really increase that process to 30 days and allow the DEA to sort of say, we see it's a problem right now, let's temporarily put it on the schedule with exceptions for research and other legitimate cases for those drugs, and take it off the streets immediately, and then be able to go back and really formally go through the process. Thankfully, the DEA came out last week with their own executive order, basically allowing them to do something very similar to that. So they've heard that concern, and it's being addressed on the law enforcement front. There's still a lot that can be done to address this. There's also a huge focus on prescriptions, on prescribing. There's there's different proposals. There's a 7-day, a 10-day, there's a 21-day, but a lot of states are going forward with their own prescription drug policies to limit first-time acute pain prescriptions. There's a McCain-Gillibrand bill in the Senate that would limit it to 7 days. My boss and Representative Swozey out of New York, we're going to reintroduce that. There's a lot of people in support of that. Pharmaceuticals are getting on board. I think everyone sort of agrees that we need to look at all of the issues, including the prescribing issue and how much these drugs are being given out, who they're being given out to. And lastly, I would say, and Jonah sort of touched on this, in terms of integrated care, the correlation between opioids and mental health is so clear in so many cases. And there are just these barriers within the system, whether it's on a local level, a state level, even the national level, getting medical doctors, getting primary care physicians, getting hospital ERs to communicate with local psychiatrists, local therapists, people who are already seeing a lot of times these people with addiction issues. How do you get that integrated care? In New York State, we've got issues with our Department of Health not communicating with the Department of Mental Health. So it's on every level, and it's something that really needs to be looked at from the basis, from the patient being able to say, I want my doctor to talk to my counselor, all the way up to Congress addressing how do we get SAMHSA to better coordinate with the CDC, to better coordinate with all of the other health agencies that are addressing this issue. On the physical health side, how do we get the mental health community more involved so we're all working to address this issue?
Thank you. We heard this morning from campus leaders from across the country, and they spoke in some detail about building a culture around mental health and wellness and really trying to move that forward for our college students. When it comes to doing that for not only our college students but our nation, what legislative policy considerations could drive us towards that goal?
So, this was teed up just for us. My boss does have a bill, the Mental Health in Schools Act. Basically what this would do, there's a pilot program in our district for on-site behavioral health clinicians to treat children, whether it's mild anxiety, whether there's some issues maybe in the home, but to really focus on the child and building that, a term that I'm fascinated with, resiliency, equipping them with the toolkit so when they encounter those difficulties, leaving home, a tough final, maybe a breakup, that they're able to handle it in a way that is conducive to long-term growth. So there's that, right? Investing in children. But then also there's a huge variation between colleges on the resources they have. Whether it's a small university, I know the UC system recently up tuition just to be able to provide on-site behavioral health clinicians on campus. So it's sometimes outside the federal purview. If it's a private school, sometimes they need to look in tuition. They need to look at different ways to utilize and to promote campus health. But my big belief is focusing on children. We always go back to the Frederick Douglass quote in our office, where it's easier to build strong children than repair broken men.
Thank you. Ms. Cunningham?
We work together on this issue day and night. So we do focus a lot on the pediatric issues, pediatric mental health issues in our country. My boss, when he first came to Congress, mental health was one of his top priorities. He had a personal connection to it, a personal tragedy that happened in his family that it's always been one of his focuses. One of the first orders of business, we created a pediatric mental health task force in our community. And it really expanded beyond pediatrics. It went into early adulthood and even middle-aged. But we got together local psychiatrists, the local hospital, the local educators, school administrators, college health administrators, local health departments, the county health departments, even some state representatives. Everyone sat down and met for the first year, monthly, basically, talking about some of the issues, researching, and came out with this report of all the gaps in our system, how children are falling through the cracks, what can we do to better address it. And I think it was very evident to us that there are a lot of ways we can get in earlier with these children in their elementary schools, in their home life, and really providing that care and that screening, just like they have physical health screenings, getting that mental health screening in at a young age. We also saw the growing need to sort of expand that, middle school, high school, even beyond college, right in those, 17 to 24 years when a lot of these severe mental illnesses start to show in a lot of kids as they're going into college, as they're leaving college nowadays. Where is that support? Where is the screening? And there was a huge interest, I mentioned integrated care before, but raising awareness with the regular medical community so that when these kids are going to their doctor, because they're not typically going to a mental health provider, really gaining sort of an extra set of eyes to just be looking out for people. So, we are really focused on how do we get at every sort of age group, at every sort of phase of life, how do we get this awareness of mental health and it being an issue, destigmatized, how do we get that into everyone's sort of train of thought from government all the way down to the citizen?
Thank you. So what laws or regulations exist that you think or believe impede access to mental health services in our country, and how does that impact our students, and what would you do or suggest that we do to tackle those?
Yeah, I think primary that comes to my mind is sort of the funding issue, and it's on every front. It's the fact that we were just talking to a woman from the University of Texas, and the state passed a great sort of suicide prevention awareness law that colleges have to start providing that information to their incoming students, but there's no funding attached with that requirement, right? We have tons of great ideas and tons of great resources that are scientifically proven to work, but if those recommendations and requirements don't come with funding, they're not going to be effective. They're either not going to go into place or they're just not going to provide the benefit that we need them to. So all the way down from sort of state mandates to on the congressional level, my boss always highlights, the Zika virus, and overnight we had immense amounts of funding going overnight to finding a vaccine for Zika, and rightfully so. It could have been an epidemic of enormous proportions, but where is that funding for mental health, an issue that we know is an epidemic, an issue that's been there since the start and continues to grow and cause a problem to a lot more families than Zika did. So raising that awareness amongst members of the government to really reallocate this funding and push it towards mental health and substance abuse and addiction is one of the primary ways. And also I'll mention on funding, there are some regulations that are just outdated, in place for cost effectiveness. But if you look at a lot of CMS's reimbursement proposals, you go through Medicare, Medicaid, hospitals are almost disincentivized a lot of times to come up with their mental health programs. So are a lot of other institutions, workplaces, colleges that want to get these things going. You're not receiving the reimbursements that are necessary to really make it profitable. So addressing sort of the inpatient cap limit at CMS, addressing the fact that we have a bill to allow mental health counselors and marriage and family therapists to be covered under Medicare. Addressing these sort of basic things that will just expand the provider pool, expand the base so that people have more access, and these sort of more sought out providers, psychiatrists are able to see the people really in need is another thing we're focusing on.
I totally agree. Oftentimes where the financial incentives are, that's where providers go. Right now, there was a report from Health Affairs, 40%, don't quote me on the number, but a large portion of psychologists take out-of-pocket payments. They're not in-network. And these can, it's great if you can afford it, but however, a lot of people with mental illness, they might be homeless. It's tough to go see a psychologist every week when it costs $200. So the financial incentives are huge. Also the culture, too. And that's tough to do through legislation. Oftentimes it's through celebrities or social movements where we can kind of turn the dial back, or forward in this case, on mental health and show that it's okay to seek help. And that's, again, tough to do through legislation. It's more of an issue of role modeling and focusing on really getting the word out there. So.
Well, let's pursue that just a little bit further. So we all would agree, I think, that education is a transformational experience, and higher education definitely has a lifelong impact on success. So we heard this morning from campus leaders about how they're struggling to manage those resources and to be sure that they've invested, and many of them are taking what little they have and reallocating it to provide more access to care. And I think many of our institutions work hard not to charge for those services to eliminate that barrier. And students are responding in droves to that, which is great. But it's stretching the institution's ability to respond to that. What kinds of things could ACHA do and our partner organizations to really get behind and lobby behind substantive efforts to address those kinds of issues?
So I get this question quite a bit, and it's something that, I struggle with because every campus has a different culture, right? So what might work on one campus might not work on another campus. I'm always fascinated by the idea of peer support specialists. Something, for example, my brother's a firefighter, big guy, big tough, job. And what they do is that he's a peer support specialist. So if someone has a tough call, for example, maybe someone passed away in a car accident and this fireman was treating them, he'll go and talk to the guy, make sure he's okay, help him process the trauma that he just saw, that he just was affected by. So having that spectrum of care oftentimes helps. Also encouraging care. There's huge gaps, both culturally, linguistically. Focusing on culture for a moment, where guys, a majority of suicides are men, but a majority of phone calls to the suicide prevention hotline are women. Just let that sink in for a moment. How do we reach out to men and let them know it's okay to seek help? I do it myself sometimes. If I have a cold or something, I'm good. I'm going to the office. You try to tough it up, but showing a bit of emotional maturity and showing that it's okay to not feel okay. And it's okay to reach out and get help. Again, each campus is going to be different. We've tried to make it a point for us in our role to, whenever we talk about suicide, we have the suicide prevention hotline, 1-800-273-TALK. If it's, for example, in Puerto Rico, the disaster distress hotline, where you can get connected to a crisis counselor. We've tried to do small things like that in our area, but also connect with celebrities when appropriate. For example, Brandon Marshall, who was on the Bears, then the Jets, now the Giants. Don't quote me on that. He's not on my fantasy team. Don't tell him that. He's been very outspoken and open about his experience with borderline personality disorder. So helping us amplify our message and reach out to new groups, where mental health affects us all, but we don't talk about it. And I commend you and your group for providing free services. They're time intensive, they're expensive, but the outcomes are worth it. You're helping people, you're saving lives. So,
what would you recommend?
Yeah, I think, outside of on the local campus level, which, we tend to defer to our colleges knowing what's best. We've got a huge university in our district all the way down to tiny community colleges. So they've all got different needs and different ways they can address this issue. But Jonah and I were just talking outside about all the different mental health organizations that we meet with weekly and the number of different ridiculous acronyms, which are a pain in DC. And I think one of the issue, and it's great to see everyone sort of coming together in this room, working with other mental health groups. You guys face unique challenges coming from the higher education realm, but the challenges are not all that unique. It goes all the way down through the school systems. It goes to other institutions, to workplaces, facing similar situations. So how can everyone sort of come together and work collaboratively to support common sense reforms? And there's a few policies that are really bipartisan in Congress, and unfortunately I think the support is just spread. And if we could really sort of unify that support behind specific policies, specific bills, things that don't even take legislation, but just take reaching out to an agency to change the reimbursement models like CMS. I think there's real progress that can be made if we just sort of unify the mental health advocacy, community to get behind simple, common sense policies.
Thank you. Do we have any questions from online at this point?
One question that we have is regarding tax. And obviously, with the tax bill rolling through and its the potential for impact on college campuses, and what does Congress, how do these issues potentially impact mental health delivery and services and colleges' ability to do so?
I thankfully don't handle tax for my boss, which I've never been more grateful for until this week. It seems to me that the two primary things that are touching higher ed in the tax bill are the endowment issues, which there's colleges on both sides of that issue in our district and across the country, and then the issue, student loan, the student loan debt deduction, and then also the sort of tax deductible, incentivized what people get paid who work at universities. I don't know the technical tax term for it, but the fact that you can deduct that. So I think outside of those issues in terms of mental health services, no one's really too concerned with that. I think, everyone sort of sees the tax cuts on our side of the aisle as a positive thing. But when you look down at sort of in our states, New York and California, the state and local tax deduction, that's a big concern. And how does that impact sort of trickle down from sort of the top people in the district who are really supporting these mental health issues? And we see it in housing, private activity bonds. Those people who are receiving the benefits that might be really wealthy are supporting these bigger efforts like mental health and low-income housing. So how is that going to play out? It's definitely a concern. I think it's something the Senate is sort of working to address more so than the House proposal.
Thank you.
And more generally, just the two provisions I know about healthcare are the orphan drug provision, where incentivizing pharmaceutical companies to try to find cures for rare diseases. Oftentimes it's, again, a physical health issue. And then the medical expense deduction, where if you spend 10% of your, I believe it's net income on medical expenses, you can deduct that. And oftentimes that's lower income individuals. It's really hard to spend $100,000 in health care if you make $1 million. So it's usually people making under $75,000 a year. How that would affect people with maybe chronic conditions like mental health that need their weekly therapy, some intensive care, could be paramount. So.
Okay, thank you. Other questions?
Yeah, another question is regarding bipartisanship or the lack of bipartisanship, and how has that impacted the ability to move agenda items regarding mental health and illness on through Congress?
Well, I think we have a lot of bipartisan support, although I think my boss bribes her boss with salsa and cupcakes. But so last year there was a large bipartisan bill, the 21st Century Cures Act, and it had a large mental health portion. For example, it established the Assistant Secretary of Mental Health, basically elevating mental health under HHS. Also, it established something that I'm excited about, if I get the acronym right, the Interdepartmental Coordinating Committee on Serious Mental Illness. Basically, mental health, as we said, affects everyone, right? It would affect people in the Department of Defense. It would affect veterans. Would affect long-term housing. Would affect HHS. So there's a lot of federal efforts around mental health, but how do they best coordinate care? But going back to your original question about bipartisanship, there seems to be a lot of recognition on both sides of the aisle that mental health affects everyone. Suicide's the 10th leading cause of death, second leading cause of death for teenagers. So how do we address that? There's been bipartisan support for appropriations for Garrett Lee Smith Act, for example. And hopefully building upon that, sometimes we do run into some of the partisan battles. But as for mental health, we've tried to steer clear of that, both in the caucus, the task force, and then our work as well.
Yeah, I think if you avoid sort of the big issues, if you avoid overall healthcare reform, tax reform, sort of the huge issues, if you don't talk about that and you talk about the specific policies, the specific things that we work together on a daily basis, our bosses see pretty much eye to eye on mental health. And that's something that not many people get down to because everyone is focused on those top line issues. And going back to my point about people unifying around specific causes or policies or proposals, if you don't focus on the healthcare reforms when you want, but when you want to move policy, really get down to that specific policy and talk to people about that one policy. Don't conflate the issues. You can really appeal to a lot of people on both sides of the aisle and unify support around things that are extremely bipartisan. And there's so many examples of that that I think, America really doesn't see. And there isn't, as much being done in Congress as anyone wants. But there's some real progress and movement, and we can continue that so long as people really get behind sort of specific policy issues that can really be bipartisan.
It sounds like that's not really felt as a bipartisan issue, or it is a bipartisan issue. There's a lot of common understanding of support for that. How do we raise something that most of us would agree upon needs to be tackled to a top-line issue where there's probably more agreement than there is disagreement about how to tackle that?
That's that's $1 million question. And it varies by office, right? Every office sets their priorities differently. If you're in a rural area, you're going to be focused on rural health. You're going to be focused on agriculture, et cetera. What helps us out a lot is hearing from constituents. It's something I say on the phone constantly, where there's a lot of people out there that care about these issues, that care about mental health, that care about suicide prevention, but they don't call their member of Congress, or better yet, show up to a town hall, or write a letter, or intern, volunteer, bend the ear of some legislative staff. And oftentimes it does help to have an actionable item, right? Where, hey, I support mental health in schools, or I support mental health on college campuses. There's this bill, HR XYZ. Can, congressman or woman support this? That usually helps out. Sometimes there's, legislative staff, I'm kind of revealing a little bit, but there's only so many hours in the day, and believe it or not, Congress is a little short-staffed. So helping us out solve this problem, I think, is invaluable. It helps us do our jobs better, and most importantly, it helps people nationwide.
What are your thoughts?
Yeah, I completely agree with that. Sort of coming to the plate, I think, with real either solutions or pathways to solutions is pivotal. I take, an unreasonable amount of meetings a week, and people are sharing their personal stories, and they are meaningful and valuable, and the congressman gets a lot out of them, but it's not as meaningful as a personal story attached to a set of statistics or funding behind it. How cost effective, right? Coming up to a member of Congress with not only why it's meaningful to you and the community, but why it's beneficial economically or any other sort of way to the government, to the country. That's something that he or she can really take to leadership and say, hey, I've got this cause that's personally very important to me and my district, but it's also really important to you because it has this number attached to it. In the long term, it would cost this much money. There's a lot more that can be done and a lot more momentum that can be gained behind something that really has sort of concrete facts behind it. And that's something that we saw in the healthcare debate. It wasn't about how much health care can we provide to people. There were definitely talks of the pleas from people and the impact that it might have, but really it came down to the numbers. It came down to how sustainable is the marketplace? What's it costing our government? How can we fund this? So, really coming through with not just sort of the personal impact, but also the really fundamental facts behind it and the stats is pivotal.
So I think you'll find that the group represented by the associations here, including ACHA, can help you attach that data and those personal stories to that XYZ bill that we were talking about. And we're looking forward to that to try to advance the issue. So we talk a lot about allocating resources to support counseling and so forth to respond to the issue. What can we do from a policy perspective to get in front of the issue? That's really what I think what a lot of us want to do in terms of prevention and education. What can we do about that?
So I often point to the states. And again, oftentimes states have, it's easier to pass bills there. It's easier to transform the healthcare delivery system. Getting involved in the state level and getting involved on, different initiatives, whether it's suicide prevention, crisis care, crisis counseling, that's vital. Also educating people. Our goal with the caucus and task force, oftentimes it seems like Sisyphus pushing the boulder back up the hill to have it fall back down, but to educate other staff and other members. So when there's the next shooting or when there's the next CDC stats come out, there's actionable items. There's we don't have to relitigate the same arguments about mental illness and guns or try to justify why mental health parity is a reality. Well, in statute, but we also need to enforce that. So states oftentimes have, they are the what's the phrase? The laboratory for democracy. It took me a moment. And NAMI does a great job. They have reports. They stopped in 2015, but different states are doing different initiatives depending on what they need. And they have these state-by-state report cards about different initiatives, different bills. I found those extremely helpful to kind of inform our work on the federal level, where oftentimes we do run into those top-line issues, and we're also kind of hamstrung where the states traditionally, since deinstitutionalization in the 50s, have kind of led the on-site delivery of care, while the federal government does shore it up through Medicaid funding, through SAMHSA block grants, but a lot of it's on the state level. And the best part about the state level is you can really make a difference. You can get in touch with legislative staff much more easy than federal level. There's more, the bodies are smaller. There's more collaboration. So.
Yeah, I definitely think the state legislature is typically faster, and in New York State, it's proven to be much more effective at addressing mental health issues than the federal government can ever come close to. Still has a long way to go, though. But I think beyond that, sort of staying in front of things, this meeting itself is a good example of people sort of staying in the know, staying in touch, staying in communication. I think there's a lot of that sort of needs to be built. The relationships need to be built. And there's these huge proposals that come out on healthcare and tax, and suddenly we're meeting with people we've never heard from before. And people are suddenly involved in an issue that they've never really reached out before to the federal government, and this happens on the state level. I think building those contacts, sort of building your arguments and your concerns from the get-go, so that when these proposals do come up, should Congress move something mental health related or a higher ed reform bill that we're hearing, they're working on, how are you guys prepared, and how are other people in the advocacy world prepared to sort of get involved in that and be a part of the discussion a week before the bill comes out, or a week before the vote, really in time to help inform some of the policy before it's written down on paper. I think getting that lead time and building those relationships ahead of time is really important.
Okay, thank you. Do we have any more questions from online?
Yeah, there's one question regarding how do the new regulatory changes have the potential to influence more low-dollar, low-coverage health plans, and how will that impact mental health coverage?
Not well. There's a lot of proposed regulations, like the workforce requirement, where someone that receives Medicaid that's able-bodied should have a job to receive health care. And we find that very concerning, where, yeah, you might be able-bodied, but you might not be able-minded, if that makes sense. If you're suffering depression, the last thing you want to do is go on a job search. And I think if you look at the Social Security disability insurance numbers, there's a lot of people that have serious mental illness that might be categorized as able-bodied. As for the waivers themselves, it's something that we had concerns about, not to get too political, but some of the waivers where my boss fought hard to have mental health as one of the 10 essential health benefits. And of course, the benchmark plans varies upon state what they mean by those. And then that's compounded by oftentimes the narrow networks or non-existent networks that when you try to get care, you find out the psychologist, hey, they retired 5 months ago. So then you keep searching for someone that will accept your insurance. We have a lot of concerns about this. We are fortunate that California has done a lot to really embrace, the ACA. But we do have a lot of concerns, like when it was included in the AHCA, and then also just monitoring a lot of the so-called, I don't know if they were referring to the CMS proposed rule from last month or some of the waivers, but we are watching it closely, and we do have a lot of concerns.
We do as well. I think it's, there's so many different proposals flying around and so many different proposed rules to roll things back or to change things that were in place under the previous administration that it's sometimes hard to keep track of it all and sort of what the potential impacts will be. And it's often hard to say when it's a proposed rule without sort of the input of stakeholders, which because there's so many proposed rules coming out, the feedback is a little delayed. So sort of waiting to figure out what the real figures are behind it is sort of, I think, where a lot of people are with the rules that just recently came out, at least. But I think, again, going back to sort of what I said generally on essential health benefits, the funding issue and how to keep these markets stable is really paramount. The reason these rules are coming out is because it's not cost effective right now, and it's not stable. We're not going to keep these insurers in these marketplaces, and we're seeing an exodus. So as much as we want to keep these requirements in place, which I think my boss and a lot of members would agree, we need to provide quality health care covering especially mental health, but all the essential health benefits. How do we do that while maintaining access to insurers in the marketplace? And that means how do we make it a viable business for them? And that's sort of the question that I think these proposed rules are going after and trying to address, and some of them, I think in a little bit better ways, and some of them in a little more destructive ways. But in order to sort of oppose these rules, we've got to come up with better solutions to address the cost issue and address the stability of the markets.
Thank you. You have other questions?
Yeah, this one might require a little bit of explanation before I ask it, but in terms of student health insurance plans, if you both are familiar with those off-exchange plans, one of the questions being asked is what steps would they recommend to advocate for using student health insurance plans in addition to Medicaid or in lieu of Medicaid? So Medicaid dollars could be used for these off-exchange plans, which oftentimes are of equal or better value than some of the exchange-based plans.
Yeah, I would say, at least for us, that's definitely more of a state-focused issue. I know that, the federal government has a say over, how states can spend their Medicaid dollars. But it really does come down to the state. And New York State has found, in some cases, it being economically viable to distribute those Medicaid funds in other ways and allow them to be used to purchase other things. And in other cases, after they study it, they realize it's not as effective. So again, for us, I think that sort of comes down to a state issue and how effective is it with the specific plans you're talking about and working with the state folks.
Totally agree. I would have said the same thing in different words.
So institutions are recruiting students from all over. I mean, and so they're becoming increasingly diverse in terms of geography and demographics. And as a result of that, they often bring the health care they bring with them, if they have it, is connected to some geographic region they came from. That creates significant issues in terms of access, in particular at vulnerable times while they're here. So that it seems like it's beyond a state issue. What can we do at the federal level to start addressing that?
One of the things that we promote is it's a term in a lot of our legislation that's culturally and linguistically appropriate care. And kind of delving down into it, I mentioned men aren't as receptive to mental health care. If I'm a Spanish speaker, I would like somebody that speaks Spanish, that I can communicate on the base level. But going further than that, it's informed care. It's knowing the culture, knowing the best practices. And what we've tried to do with SAMHSA, they often have resources for clinicians. They have best practices that they promote, and trying to inform care that is linguistically and culturally appropriate. They have different centers that, we've actually just sent a letter about this for the Hispanic Latino National, forgive me with the acronyms. Basically, there was a center that provided this linguistically and culturally appropriate training for substance use for Latino and Hispanic populations. And that was defunded for whatever reason. It was a small amount of money, and we're looking for a reason why, where we do need to promote, cultural diversity, both in behavioral health, where it's paramount, the relationship you have with your therapist, with your psychologist, with, it's a very emotional and vulnerable issue. So you need somebody that speaks the same language, that knows, kind of what you've been through and what the expectations are in your family and what the expectations are in your neighborhood. And SAMHSA does do, they do a good job overall, or they try to do a good job overall, let me rephrase that, bless their hearts, promoting those resources and promoting evidence-based treatment that is both culturally and linguistically appropriate.
What are your thoughts about improving access outside of their networks?
Yeah, I think, first of all, I think there are some federal policies in place that do work to address that issue. I think there's a lack of education on that, and it's also on the state level. I live in Maryland, and there's some phenomenal requirements there, but they're also on the federal level that if there isn't someone in your network that provides an essential health benefit in the way that a prescriber requires you to get it, you can do an appeal process through your insurer and be provided in-network coverage for that. And that's something that, if I weren't in healthcare policy, I would have no idea about. And no provider, pointed me or would point a normal patient in that direction. Most providers are not aware of it. So I think being aware of the resources that are already there and the appeals processes that are already in place is critical for people sort of in these support roles and provider roles to educate patients and students on their rights, as well as addressing sort of the gaps and how long that appeals process takes. How do we better coordinate with these insurers to say, it's not just the patient's loss, it's also your loss, that it takes you 6 months to get this letter back to them because the cost of care goes up. So I definitely think there are things in place, and raising awareness and educating people on those is crucial, but there's definitely a ways to go.
Okay. We perhaps have time for one or two more questions. Anything from online?
Yeah, this question also may require a little bit of explanation, but in essence, with telecounseling and telepsychiatry on the rise, and obviously a complex subject, what is Congress's opinion and thoughts on this?
Well, I can't speak for Congress, but we are a big proponent for telepsychiatry, telemedicine overall. We think it's a great use of the patient's time. The only concerns that go along with it that we've seen are security, where there's an uptick in hackers, seizing health information because it's easy and holding it for ransom. So ensuring that the communication is, secure would be paramount. But as for, it's more efficient for time, it saves money, and it improves coordinated care. So.
Yeah, I definitely think there's a pretty good bipartisan consensus in Congress that this is a really way that we need to go in the future to save money, to provide better care. Every member represents a different district, but most districts have sort of polarizing ends between their rural and their urban centers. And that is the primary driver we see for members really understanding how critical it is to have this technology. And this is one of the areas I think the mental health advocacy world has been really strategic in terms of getting behind physical health on this issue. Cardiologists have long advocated for telehealth services for issues that really need to be immediately addressed, determining if it's a stroke, determining things really, within a matter of hours to treat it. That's something that they knew they needed to sort of increase their technological abilities and get reimbursed for them so that people out in the middle of, Wayne County in our district, 2 hours away from Syracuse, can get that quick answer and then be quickly shuttled into the city if they need that urgent care. And the mental health community really got on the backs of that and said, yes, absolutely, and us too. And that's something where, there can be that collaborative effort between the physical health, the doctors, and the mental health community to say everyone needs this ability and everyone needs these reimbursements for different reasons, but it's just as important for mental health as it is for the physical health side.
Any other questions?
Just a follow-up with that was, what limitations are there to telecounseling and telepsychiatry that maybe make that difficult to do?
I think insurance coverage is a big one, and getting everyone on the same page. I mean, having the federal government reimburse through Medicare, Medicaid is vastly different than getting the insurers on board to reimburse for that. And also, I think another barrier is how many in-network providers that accept or work under Medicaid, Medicare, or insurance policies, how many of them in the mental health field are using this technology? My understanding in our district and in a lot of places, can typically be out-of-network providers who don't accept insurance. So automatically you're limiting who can access this technology, and often it's low-income people who don't have the ability to travel to receive these services that need access. So how can we expand telehealth so that more providers that are in network seeing low-income Americans, more of them are using it? That's something that sort of happens on a state and local level.
Completely agree. I was going to pick up on the last part you said where a lot of people, they might not have access to internet or they might not have access to the technology. I know, for example, just in my family, I have some family that live in a rural area where, cell reception is spotty. So trying to get a doctor's appointment through telemedicine might be difficult for them. Although, it's the exact population you want to reach are rural Americans who, have to drive 2-3 hours to go see a specialist.
So just kind of pursuing that a little bit further. So some of the limitations that we spoke to earlier about network limitations beyond states, and then when we think about college students and their dependence upon Medicare and Medicaid, those don't always line up very well. So those are things that we're going to need to try to figure out how to tackle to address the needs of the population that this group is mostly focused on. Because limitations there. So we've had, I think we're at the end of our time that we've made here. We appreciate all the discussion. We appreciate those that joined us online. We especially appreciate you, both of you, and your staff and your offices for making time to come and participate in this discussion. And I think that you'll find that if there's an opportunity for us to work to support, to advance some of these ideas, that ACHA and our partner organizations will definitely have an interest in trying to get behind those kinds of things. So thank you for your time.
Thank you.
Everybody gets to make a case. That's how we were able to increase the number of counselors on our campus. When clinic started, there were 1 person, and now we have 9 total. So every year over the last 9 years, we kept adding. That means they made a really good case, and it shows the need for it. So we did increase the funding for it. When you ask about one-time funding, we are a campus of 12,500 students today. So you always have to keep some in the reserves to take care of this funding when these sudden things happen. My bigger challenge as I see into the future of higher education is the free speech movement that has taken over. And I always say, hey, I'm all for free speech. I want the left speakers, the right speakers, and come talk to us, but I can't afford free speech in terms of security and the cost it takes to bring the speakers on campus. I would rather give that money for scholarships. So you're going to have these special instances that are going to happen, and you have to figure it out. And this is no different in that sense, that you have to provide it. Just this is more funding as well as innovative way of doing it. Our director of mental health is really working on a train the trainer program. That means, how do you prepare others? How can you help faculty see that some student is at risk, and so they can kind of go and help those people? So you can stretch the dollars as well by being a little bit more creative and innovative, and really expand the services by including other people in the process.
Yeah, well, I agree with all of that. Something a little bit more mundane. I think each school probably funds their services in different ways, and you have to think about sort of revenue. But just a problem that we had that goes to sort of helping teach responsibility is that with the backlog and the demand for counseling, we were running into a problem with students who made appointments that didn't show up, and which creates problems for not only our counselors but other students who desperately need those services. So what we're implementing is a fee for those who do not give us 24-hour notice if they don't show up for their counseling session. It's not a punitive fee. It's fairly minor, and it's not going to help solve our revenue problem to support this work. But I think it does send a message to those students that if you schedule appointments, that's people's time, which is a drain on our resources if our counselors are not being used effectively, and certainly it also affects other students who desperately need those students.
And then in our final 2 minutes, I'll give a very easy topic for you that you can wrap up quickly. Board of Trustees and Board of Regents. That's simple. So in the next 90 seconds, if all of you could comment on the approach to working with your boards of trustees and making sure that they understand about mental health and preventive needs. And I guess one of you gets to take the final word on that. So it's up to you.
I'll start and let somebody else have the final word. 2 quick things. One is awareness. I just continually find the board needs to be made aware of what we're dealing with on campus and how important it is. The second, and we're fortunate, the Board of Regents in Maryland, one of the regents is an MD, and she has become the advocate for that among the regents. So I would encourage presidents who are working with the boards to find an advocate on that board to make it work.
So I've had 2 different boards, one at Truman, one at Mary Washington now, and I just don't think you're going to find a collection of members who haven't had direct interaction with this issue. And so the interest is there. They want to know about it. I have 2 board members right now who've lost children to suicide. So you don't think that they care deeply about this issue. They want to know. They're fully engaged. So this is something that they're asking even before we have a chance to present, quite honestly.
2 things. I think presenting them with the data so they understand the demand and the stress on the system that we're facing. So making sure that that's part of the dashboard that my board receives at every board meeting, kind of number of visits, number of students who withdraw for mental health issues. And if they weren't aware, those numbers really get their attention. And the second, the board just recently kind of restructured some of their committees to focus more on risk campus-wide. And this clearly was the #1 topic as part of the risk that they wanted to look at. They're always very focused on financial risk and those types of things, but they said really we need to be looking much more holistically at this issue. And I think that's wonderful because it will bring not only the health and the student affairs side together, but across all the areas that the board's responsible. And I think I'm happy for that increased attention because I think these are problems that we need our boards to help us deal with and help solve.
Well, I agree. I mean, the awareness is the most important thing to do. And we talked about board being interested in the financial risk. This is a financial risk. So when you educate the board, when they talk about we need to increase retention and graduation rates, we can educate them from that side also if they don't understand from the purely mental health side. But I do assume good intentions. They want to do the right thing, the board members. So I keep preaching about we all need to work on this as one team, because at the end of the day, our goal is to help students succeed. And if we don't address this issue, we are failing on that issue. So I think educating the board, just like we're educating ourselves, I think is important, but also put that in perspective that the implications are not just on the student, but it's on the family of the student, the campus, the community. It's a much, much broader issue rather than just one person being affected by it.
Mike, we actually have one question that came in online. If you could throw that out there unsolicited. Somebody online asked, why is providing essential mental health resources considered a resource drain when academic initiatives are characterized as investments?
Well, I think that's a great question, because I think that everything is an expenditure of some sort. But I do think that the way of looking at this is an investment in mental health helps our students be successful, and it connects to all the other goals that we talk about, retention and graduation. You can't be successful if students aren't able to meet the challenges of their day-to-day lives. So no, I do think it's an investment. I think the reason why it's probably different is that there's not a direct revenue stream connected to this particular cost. So I think that's why it's oftentimes characterized that way.
Could I just add to that?
Sorry, please, Dr.
I would say the impact is today the students coming into college are lifelong learners. They're going to keep coming back to college. So we have a responsibility to make that investment. Secondly, now universities also are held to help our communities thrive. And these students are going to enter that community. So we have a much bigger responsibility from K through 12, through college, through beyond into the community. So addressing this issue in collaboration with all those entities is critical. So it is an investment.
When you're putting together a symposium, your one greatest wish is that your opening session will be perfect. And I think we have achieved that today. I'm so grateful, and on behalf of ACHA and all of our partner organizations, I want to thank Dr. Andrea Chapdelaine of Hood College, Dr. Ronald Nowacek of Frostburg State University, Dr. Troy Pano of University of Mary Washington, and Dr. Venkat Reddy of University of Colorado at Colorado Springs for a really excellent and thought-provoking first session. Thank you.
Thank you.